Tracheostomy, Medical Surgical Nursing, Advanced Nursing Practice, 20 marks. Define tracheostomy. 2 marks. Immediate post-operative management. 8 marks. -3 Nursing diagnosis and prepare care plan. 10 marks. Introduction. Tracheostomy is derived from Greek word tom, to cut the tracheostome, mouth. Tracheostomy, surgical opening into trachea / creation of a stomach between trachea and cervical skin. Surgical procedure to bypass the airway in the patient with upper airway obstruction, to make tracheobronchial toilet easier in the patient with decreased consciousness or for the need of mechanical ventilation. Definition: an artificial surgically created airway fashioned by making a hole in the anterior wall of the trachea and the insertion of a tracheostomy tube, which may or may not be permanent. Tracheostomy can be defined as surgical opening of the trachea. Tracheostomy can be defined as the creation of a stoma under the skin surface which leads into the trachea. Tracheostomy can be defined as a surgical procedure in which opening is made in the anterior wall of trachea and converted into a stoma on skin by inserting a tube. Types of tracheostomy depending on the timing: elective or routine, emergency depending on the cause, permanent, temporary depending on site. High, about isthmus through first tracheal ring, mid through second, third tracheal ring, preferred low below level of isthmus cuffs to protect airway to allow ventilation. Single/double lumen. Double lumen allows easy cleaning. Single lumen has a greater internal diameter. Types of surgical airway: 1. Elective tracheostomy. 2. Emergency tracheostomy. 3. Cricothyroidotomy or mini tracheostomy. 4. Percutaneous dilational tracheostomy. Cricothyroidotomy procedure for opening airway through cricothyroid membrane. Emergency procedure when endotracheal tube intubation is impossible. Contraindicated in children less than 11 years. Trauma to larynx, cricoid cartilage subplot. Academic and stenosis are very likely. Keep only for 3 to 5 days. Elective bleeding disorders. Permanent tracheostomy. The trachea is permanently disconnected from the pharynx and the proximal end of the trachea is sutured to the skin. Permanent tracheostomy is an elective procedure carried out as part of an operation involving removal of the larynx. 50. Laryngiotomy or laryngopharyngectomy. Temporary tracheostomy. A temporary tracheostomy may be in use permanently, however it differs from a permanent tracheostomy in that there is still a communication between the pharynx and the lower airway via the larynx. In permanent tracheostomy, the only access to the lower airway is through the tracheostome. Indications: upper airway obstruction, pulmonary ventilation, pulmonary toilet. Elective procedure: prolonged incubation, upper airway obstruction, tumors of oropharynx, larynx and trachea, infections of epiglottis, severe tracheobronchitis, bilateral vocal cord paralysis, trauma to laryngeal, maxillofacial fractures, foreign body obstruction, subglottic or tracheal stenosis. Pulmonary ventilation. Tracheostomy should be performed in patients to require ventilation through an endotracheal tube for more than 1 week. Pulmonary toilet: removal of secretions, congestive cardiac failure, infection, pulmonary edema, and bulbar palsy. Those who cannot cough and clear their chest, prevent aspiration. Upper airway obstruction due to trauma, foreign body infections, malignant lesions, vocal cord palsy. Pulmonary ventilation. Tracheostomy should be performed in a patient still requiring ventilation through an endotracheal tube for more than 1 week. Pulmonary toilet: those who cannot cough and clear their chest, prevent aspiration by low pressure, high volume cuff tracheostomy tube. Elective procedures for major head and neck operations. Anesthesia: general anesthesia is used unless the situation is critical. Local anesthesia with 2% lignocaine can be used in case of emergency. Atropine is used to decrease secretions. Preoperative workup: history, physical assessment, anesthesiological assessment, complete blood count. Prothomin time, PTTINR, coagulation profile, informed consent. Regarding operation procedure: loss of voice, ventriculostomy, cannule still in the trachea, complication of operation, patient preparation, cardiac monitor, intravenous line with saline, oxygen, pulse oximeter, ambubag for ventilating patient, adequate lightning. Tracheostomy set profile: lactic antibiotic, cefazolin, patient position in supine with hyperextension of the head, give a cushion below the shoulder. Trachea will be exposed to the anterior. Rest the head on a donut cushion. Set up: provide iodine solution, surgical drapes to enclose the field, sterile gown, gloves and mask. Put patient 100% FiO2 and continuously monitor the patient. Follow strict aseptic process. Skin preparation with pavadine, iodine, chlorhexidine, sterile draping, good light source and suction apparatus ready and tested to be functional. Ambubag, face mask, standby. Appropriate sized tracheostomy tubes must be available if the patient is obese and has a short neck. Thick neck, A longer tracheostomy tube should be used. Procedure: local anesthesia, 10 ml syringe, 1% lidocaine, 18/25 gauge needle, #11 scalpel blade and handle, 2 skin forceps, 8 small curved hemostats, sterile, 4x4 gauze squares, 2 dozen, 2 Kocher forceps if needed to clamp thyroid, Fraser suction catheter with suction tubing, suture ligatures, 3-0 chromic, 3-0 silk, 3-0 nylon, tracheostomy tube. Appropriate size for patient, water-soluble lubricant or aesthetic jelly, suction source and tubing. 2 pairs of scissor, 1 straight and 1 curved, 2 tissue forceps without teeth, 2 Alice forceps to grasp the trachea, 2 small rakes for exposure, mastoid retractor, tracheodilator, 2 tracheal hooks, umbilical tape, needle holder. Procedure of elective tracheostomy: proper analgesia and sedation along with local anesthesia, good illumination, preferably headlight. Look for any anatomical distortion. Check the tracheostomy tray position, supine with sandbag under the shoulder, skin 5 cm. Insulation midway between cricoid cartilage and suprasternal notch, horizontal cosmetically better and vertical avoids injuring vessel and bleeding subcutaneous tissue and deep fascia. Use electrocoagulation. Anterior jugular vein may require libation. Extend the incision to entire length up to 2 address of skin and do not work in a small hole. Pretracheal muscle splint it at midline. Transverse incision 1 cm below the cricoid or over second tracheal ring. Incision length 2 to 3 cm. Blunt dissection of subcutaneous tissue transversely retracted until the thyroid isthmus is identified. If the gland lies superior to the third tracheal ring, it can be bluntly and determined and retracted to gain access to the trachea. If isthmus overlies 2 and 3rd tracheal ring, it must be either mobilized or a small incision is made to clear a space for tracheostomy. It must be either immobilized or a small incision is made to clear a space for tracheostomy. A window of tracheal tissue is removed. This window is approximately the size of desired tracheostomy tube. The endotracheal tube should be withdrawn till it is just visible about the proximal end of the stomach and leave endotracheal tube in place. The endotracheal tube not be completely removed from the airway until the correct placement of tracheostomy tube is confirmed and secured. Trachea is maintained open with blunt hooks on the right and left. Clean existing secretions by using suction catheter while inserting the tracheostomy tube. Position the axis perpendicular to the tracheostomy tube. After entering, turn the direction parallel to the axis of trachea. Proceed according to the curve of the tracheal tube into the lumen of trachea. Check tracheostomy tube into the lumen of trachea. The whole latch is released. Assistant hold the tracheostomy tube. Then it is fixed with sutures at the right and left flanges of tracheostomy tube to the skin of the neck and installing a ribbon strap around the neck. If the incision is too wide, skin is sutured loosely between tracheostomy flange and skin. Put sterile gauze cushion. Then tracheostomy tube, TT, is connected to the ventilator and endotracheal tube, ETT, is pulled out. Post-operative management nursing job with medical responsibility. Regular gentle suctioning. Meticulous wound and stomach care. Primary goal is to keep tube in stoma. Tube change after 5 days if required. Earlier can be risky and do not normally need to be involved in all aspects of trachea care. Repeat X-ray. Soft tissue neck analgesics, antibiotics, intravenous fluid until able to tolerate orally observation for the first 24 hours. Tracheostomy cannula management function of the secretion/hour. Cleanse the smaller cannula per 6 hours. Nebulizer with warm air for 15 minutes/6 hours. Treat tracheostomy wound with gauze replacement. Every treatment. PCV check pressure controlled ventilation. Greater care of a tracheostomy. Caring for a tracheostomy tube. Suctioning to prevent occlusions and replacing tubes. Because of the lack of filtering and humidifying by the nose and the ineffective cough mechanism, there is a buildup of secretions. Suctioning is only performed when clinically necessary because there are many potential risks. The suction catheter is inserted no more than once past the length of the tube to avoid contact with tracheal tissue. Suctioning is done during withdrawing the catheter at least ½ inch. Risks also include atelectasis or collapsing lung tissue from high suction pressure, and so pressure is limited to 80 to 20. Sterile suctioning as prone to infections. Gases given should be humidified. Emergency equipment should be immediately present at bedside. If the tracheostomy is temporary, the tube will eventually be removed. Healing will occur quickly, leaving a minimal scar. Sometimes a surgical procedure may be needed to close the site or stoma. Occasionally a structure for tightening of the trachea may develop which may affect breathing. Most people need 1 to 3 days to adapt to breathing through a tracheostomy tube. It will take some time to learn how to communicate with others. After training and practice, Most people can learn to talk with a tracheostomy tube. Tube changes indications: soiled cuff rupture avoid within first week. First tube change by surgeon. Difficult cases like obese, short, thick neck. Be prepared for endotracheal intubation. How to suction a tracheostomy tube. 1. Connect the catheter to the suction machine. Do not touch the end of the catheter that will go into the tracheal tube. 2. Insert the catheter to the proper distance into the trach tube, usually the length of the trach tube plus 1/4 inch. 3. Apply suction by putting your thumb over the hole in the catheter while you gently pull the catheter back out. Gently roll the catheter between your thumb and forefinger as you pull the catheter out. Risk factors for complications: age, infants and adults over 75 years, obesity, smoking, poor nutrition, recent illness, especially an upper respiratory infection, alcoholism, chronic illness, diabetes. Benefits of tracheostomy: more comfortable and more suitable and more stable. Tube size can be larger. Less resistance allows tube to be changed more easily. Better quality suctioning depending on indication for tube and the type of tube. Patients can eat and talk. Can promote oral nutrition. Complications of tracheostomy: intraoperative complications, loss of airway, injury to tracheoesophagus wall, bleeding and injury of blood vessels, pneumothorax, aspiration, hemorrhage, bleeding, air embolism, apnea, due to sudden carbon dioxide washout, false tract, direct damage to the vocal cords, injury to adjacent structures like recurrent laryngeal nerve, the great vessels and the esophagus, post-obstructive pulmonary edema, hypertension, arrhythmias, local damage to thyroid cartilage, cricoid cartilage, and recurrent laryngeal nerve, cardiac arrest, pneumomediastinum. Intermediate complications: dislodgement or displacement of tube, subcutaneous emphysema, pneumothorax or pneumomediastinum, scabs and crusts, infection, tracheal necrosis, tracheoesophageal fistula, dysplasia, anesthesia. Complications: crust formation, dysphagia. Early complications: bleeding and local hematoma. Bleeding result with increased blood pressure as a patient emerges from anesthesia and begins to cough. Plugging of the tube with mucus, cellulitis, tube displacement, subcutaneous emphysema, atelectasis, tracheostomy tube obstruction and desaturation, tracheostomy tube displacement, infection, surgical emphysema. Late complications: tracheal or subglottic stenosis, tracheal stenosis, septicemia, granulation tissue, tracheocutaneous fistula, tracheoesophageal fistula, dislocation of tracheostomy tube, bleeding from stoma or during suction, blockage of tracheostomy tube, laryngeal injury or alteration of phonation. Long-term complications: subglottic stenosis, tracheal stenosis, esophagotracheal fistula, increased bacterial colonization of the airways, vocal cord dysfunction, stromal granulation and scarring, non-healing of wound, swallowing problems. Tracheostomy tubes: plastic Protex/metal, fenestrated or non-fenestrated, cuffed or uncuffed, single or double lumen components of tracheostomy tube. Size range from 2.5 mm to 11 mm. Curved tube, inflatable cuff, flanges with holes. Tube bladder care of patients with tracheostomy, hospitalization, voice rest, airway management, oxygen, tracheostomy, humidification of inspired air, steroid safety, first care of stoma, communication, psychological, nutrition, infection control. Call bell, paper, pen, half-hourly or hourly suctioning using sterile character. Install few drops of normal saline, ring or lactate, 5% soda bicarb into trachea every 2 to 3 hours to loosen crusts. Use wet gauze for proper humidification to prevent crusting. Inner tube cleaned every 4 hourly. Deflate cuff tube for 5 minutes every hourly to prevent tracheal stenosis. Antibiotics, mucolytics, anti-inflammatory, chest physiotherapy. Daily dressing of stoma, temperature, pulse, respiration, BP. Care of stoma or infection control: it needs to be cleaned and inspected 2 to 3 times a day. It should be cleaned using aseptic techniques and appropriate dressings applied to aid healing. Once tube is removed, the stoma will close spontaneously over a few days. Psychological/communication: patient and family require reassurance and support. Alternative methods of communication should be sought. Provide stimulation in the form of television, radio, newspaper. Nutrition: check local policy on eating and drinking with tracheostomy. Some trusts allow patients to eat and drink. Usual ways of feeding include oral, nasogastric, parenteral. Changing the tube, railroad technique: cut both ends of largest possible suction catheter. Insert suction catheter down tracheal tube. Remove tube over capital, maintaining catheter position in airway. Insert new tube over catheter. Remove catheter. Checking tube position: feel airflow from tube on your arm as patient exhales. Observe patient's breathing, noisy, difficult. Use of accessory muscles. Observe patient's color. If any doubt, fiber optic scope can be passed down. TUBE for direct vision of position. X-ray not generally helpful. Decannulation: the process by which tracheostomy tube is removed when the patient no longer needs it. The process of weaning the patient of the tracheostomy tube once the causative condition treated when ventilation or suctioning no longer needed, and patient can control their airway and not be at risk for aspiration resolution of pathology that necessitated the tracheostomy for upper airway obstruction, pneumonia, normal protective laryngeal mechanism like no aspirations during, normal swallowing, good coughing, no plano for the interventions like radiotherapy operations, no mechanical ventilation.